Hello, everyone. I hope you can hear me. Now it's too loud. Okay. All right, welcome back. So, yesterday we started our discussion. We first looked at how obesity is managed. We looked at the 5A's process, we went through it, and what each stage talks about. We moved on to look at food intake regulation, looking at the different gut peptides. And for the gut peptides that we focused on, we looked at GLP-1, and then we also looked at ghrelin. We talked a little bit about leptin as well, which is a hormone which has longer-term food regulation, is responsible for longer-term food regulation. We talked about leptin. We saw that leptin levels are higher in people with obesity. However, there is also leptin resistance. And so leptin, ideally, if you have elevated levels of leptin, you should have a suppressed appetite. But because in obese people, they have leptin resistance, it doesn't give the expected response. So we also moved on to our third section, and our third section we said was going to look at weight management in different life stages, and we started talking about pregnancy, if we recall from yesterday. And so we looked at weight gain during pregnancy, and we did see that the amount of weight gain that is recommended for a woman during pregnancy is based on their BMI going into pregnancy, and we'll look at some of those cutoffs in a second. But on average, for a normal weight, so normal BMI range, woman going into pregnancy, it is recommended that they gain about 12 kilograms. And this shows where the different weights go into. So we saw things to do with the uterus, things to prepare the woman for lactation later on if they choose to breastfeed. One important thing to remember is that there are risks to both the mother and the baby if too much or too little weight is gained. And so when there's too little weight gained, that can lead to issues for the mother and also for the fetus. And then when there's too much than recommended, that can lead to problems as well. And we'll see some of them as we go through our discussion. So as mentioned earlier, weight loss is not recommended during pregnancy, as it puts the fetus at risk for nutritional deficiencies. And so women are advised that if they are overweight, if they belong to the overweight or obese BMI categories, that they should not consider weight loss during pregnancy. However, they can do that before pregnancy. And this can happen if it's a planned pregnancy. And so when women go into pregnancy on the heavy side, weight gain should be kept to a minimum. And so we'll see that different weights are recommended depending on how you go into pregnancy. And so the graphic here shows that if a woman begins pregnancy with a BMI greater than 30, then her recommended weight gain over the course of the pregnancy is much lower than the weight gain recommended for a mother who begins pregnancy underweight. And so when we look at the graph, we can see weight plotted against gestation weeks. There's the number of weeks of pregnancy. And so for an underweight woman with a BMI less than 18.5, that's the red line, we can see that the weight gain that is recommended is much higher than what will be recommended for someone in the normal ranges. Okay. However, if the woman starts off in the obese ranges of BMI, that's a BMI greater than 30, then weight gain is still recommended, but it is much lower than what will be recommended for a normal weight person. And we can see overweight is also a bit lower, but not as low as for the obese person. And this is important because you do need the weight gain to support a healthy pregnancy. And so even for someone with a higher BMI, there still needs to be some weight gain, although on the lower ranges. Okay. So additional energy is therefore required during pregnancy to support the growth of the developing fetus. And so as we can see here, Canada's DRI recommends an additional 350 to 450 kilocalories during the second and the third trimester. And this is when you see a lot of muscle accretion, or the fetus begins to grow much bigger. And so there is a higher calorie need for the mother. So we do know that pregnancy is divided into 3 trimesters. And for a pregnancy to be considered full term, it has to be 40 weeks. So the first 13 weeks is the first trimester, the second set of 13 weeks. So anywhere from week 14 to 26, that will be the second trimester. And the third trimester will be from weeks 27 to week 40. And it's during the last 2 trimesters that most of the fetal growth takes place. And that is when an additional 350 to 400 becomes important. But it's important to also note that an additional 350 to 400 kilocalories is a small amount of food. It's not a lot of food. And so very often there is this myth that you hear older women tell younger women, you're eating for 2. And so women will often go by the fact that they're eating for 2. And it's important to notice that if you go over what is recommended, which is around 350 to 400 for someone who is normal weight, you will end up gaining much more weight than what is recommended. And sometimes it can be difficult losing it after pregnancy. Okay. And so when you think of an additional 350 to 400 kilocalories, as I said, it's a small amount of food. This could be just a fruit and yogurt, and you're already at 400 kilocalories, or cereal with milk, or a small salad. So it's not a lot more food that one needs to be consuming during the second and third trimesters. So shown here, we see a graph that illustrates the relationship between maternal weight gain and birth weight. And we can see here that mothers that gain less weight during pregnancy are more likely to give birth to a small baby, which we often refer to as small for gestational age, or a low birth weight baby, so a baby who has a weight that is lower than what is considered the normal ranges. And we'll see the numbers in a second. So on the other hand, women who tend to gain a lot of weight will also end up having very large babies. And in the case of mothers who may have type 2 diabetes that is not well managed, or gestational diabetes that is not well managed during pregnancy, they end up with really huge babies that are often will have to be delivered by C-section delivery. Okay? And so this is when we call the babies a macrosomic baby, much bigger than what is recommended. Yes?
You say large for gestational weight, that just means like large, relatively, like large for the baby.
Yes, so there are normal ranges with regards to numbers. And so when we say large for gestational age, if it's a full-term baby who is about 40 weeks, that's 40 weeks of gestation. There is a normal range for a child that is a fetus that develops up to 40 weeks. And so usually for a large for gestational age baby, their weight is way higher than what would be expected for a normal term infant.
So basically what it's showing is like a higher weight gain means it's going to be less babies that are, or more weight gain is going to be more babies with a large for gestation age and less babies with a lower.
So if I understand your question, ideally you want to keep babies in the normal range, right? When you're thinking of the health of the baby long term, and also the well-being of the mother during birth and after, being in the normal range has lesser risk of negative outcomes, whether it's during birth or just the health of the baby itself. And so you don't want a low birth weight baby, because they're at higher risk of a lot of negative outcomes, even including fatality as well. And so you want to keep them in the normal ranges and not way above as well. And so recently, research has shown that the mother's health status can influence the health of the child, not just at birth, but over the lifespan of the fetus. And this is a process that's often referred to as fetal programming, okay? or sometimes you hear it being referred to as the developmental origins of disease. What this means is that a poor fetal environment, so we're talking about the environment in the uterus, in utero. Okay. So an undernourished mother, for example, if you have an undernourished mother who is not eating optimally, and so whether you're looking at macronutrients or micronutrients, they have less than what is required for them. What you often end up with is a low birth weight baby. Okay. So this low birth weight baby is programmed to have what's called the thrifty genotype or the thrifty epigenotype. And so if you focus on the blue font on the slide, you see that this can result in adult obesity. And so what's been found out is that, let's say you go to a very low resource setting and the mother is undernourished. So they are not having adequate amounts of calories, they don't have adequate amounts of micronutrients. They end up having their fetus being programmed in the uterus to use very little calories. And some of these adaptations that happens in the fetus puts them at a higher risk of metabolic syndrome later. So they are at a higher risk of high blood pressure, they are at a higher risk of obesity, they are at a higher risk of not having the right lipid profile, putting them at a higher risk for these chronic diseases. So if you recall, we talked about how weight bias is not fair. This is one of the reasons why it's not fair, because this programming happens to the fetus without their knowledge, and they have no control of what led to that. And so this will be one of the reasons or one of the pathways how someone can be at an increased risk of chronic diseases by having an underweight mom or a mom who is not optimally nourished. And so if this infant, still keeping to our storyline, if this infant are then born into an environment, and so for example, they were born in a low resource setting, and that's what leads to the mother not having optimal nutrition. But then later on after the child is born, let's say they moved into a place where there's a lot of food, like a different setting, which has more resources. And so what happens is that in this setting where food is plentiful, if the infant engages in a lot of food, especially when they're eating foods that are not of the best kind, so high saturated fats foods, foods that are high in sugar, all the detrimental nutrients that we've talked about, then this infant becomes increasingly at risk of developing obesity because of the programming that happened when they were fetus. So this epigenotype refers to the pattern of DNA methylation, which results in this switching off and on of certain genes. Again, this will result in differences in metabolism between stressed, so when we talk about stressed infants that have been exposed to this injury in the womb, and those that were born in optimal environments. So for example, when we look at research from immigrant groups, for example, especially if the immigrant groups are coming from very resource-constrained settings, the effects of fetal programming may not be as pronounced if they remain in the same settings that they were born. However, when they move to obesogenic environments, which are environments that have foods that have high saturated fats, foods with high sugars, high sodium, they become increasingly at risk for chronic diseases. And this is as a result of some of this fetal programming that may have happened. Okay. And this is why we may see increased obesity and related chronic diseases in immigrant populations, especially if they were coming from low resource settings as well. So the best example of this in utero programming or fetal programming was the concept came from a very early study that was done in 1944. And this was a study that was done after the 1944 Dutch famine, which was due to World War II. So researchers found out that when they examined people who are exposed to famine, so these are fetuses, people who were fetuses and their parents were exposed to the famine, and compared them to siblings who were not exposed to the famine. So these were kids that were had a bit later on when the famine had passed and there was more resources. The people that had the famine exposure in utero had an increased risk of developing obesity in adulthood and developing risk factors for cardiovascular diseases, such as lipid profiles that supported plaque formation, such as increased risk of hypertension, such as impaired glucose tolerance, and prediabetes, and things such as coronary heart disease as well. And so it's interesting to note that smoking during pregnancy today has a similar effect. And so smoking during pregnancy puts the fetus at a higher risk of some of these conditions that we've talked about. So now, while this is interesting proof of concept of fetal programming, when we look in Canada today, there aren't too many starving mothers in Canada. So if there's a fetal programming of obesity, its causes are a bit different from some of the ones that we've talked about in underweight women or undernourished women. And one of the concerns is the presence of diabetes in pregnant women. So we talked about gestational diabetes when we're looking at the different types of diabetes, or pre-existing diabetes. So a woman could get gestational diabetes as a result of the pregnancy. This is just diabetes that is developing during pregnancy. And then there could be the case where a woman already has type 2 diabetes going into pregnancy. Okay. So very similar to the Dutch famine study, another one was done where researchers compared children born after mothers developed diabetes and then those who were not exposed to diabetes in utero. And so when they compared these siblings who were born before diabetes and after diabetes, when these children were observed as adolescents, those exposed to, like when their mothers had, who were born when their mothers had diabetes, had higher BMIs. And so on average, it looked like those who were born when their mothers had type 2 diabetes or gestational diabetes had a BMI on average of about 24.6 compared to an average BMI of 20.9. And so although both of these numbers were considered normal body weights, it's clear that the diabetes group had heavier BMIs compared to those who didn't have, who weren't exposed to their mother having diabetes when they were fetuses. So they also found that fetus born to mothers with diabetes had an increased concentration in their amniotic fluid of insulin. So they had elevated levels of insulin in their amniotic fluid, suggesting struggles with sugar control even while they were in the womb. Okay? And this has been associated with an increased risk later in life of obesity, first of all, and also of impaired glucose intolerance. Again, another reason why weight bias is unfair, because the fetus has no control over this. Yes?
There's more insulin in the amniotic fluid if the mother's diabetic during pregnancy.
Sorry?
There's more insulin in the amniotic fluid if the mother is diabetic during pregnancy.
Can you ask that again?
The mother, if she's diabetic during pregnancy, there's going to be more insulin in the amniotic fluid, like more concentration.
Why do you think so?
I mean, there's like less,
Well, if the diabetes is not well managed, I guess yes. If it's managed with medication and it requires insulin, very often there's insufficient insulin is the case with gestational diabetes. And so they will be supported. So it's typical to see women who are going through gestational diabetes being given insulin when they require it, especially when the diet therapy doesn't work for them in managing the risk. And so, in the case of gestational diabetes, because of the risk associated with having a macrosomic baby and the complications that result from that, very often insulin will be provided as a way of managing it as well. Okay. But then what they did find, they also did find poorer intellectual and psychomotor development in the women, in the infants or the now adolescents who as fetuses were exposed to diabetic mothers as well. Okay. So we also know that some risk factors for adults obesity occur in infancy. So babies born with increased birth weight, or those who are not breastfed or not breastfed regularly have an increased risk of obesity. And therefore, the recommendation from Health Canada is that infants be exclusively breastfed for the first 6 months of life, at least, and it can be continued to 2 years, if so desired. And rapid weight gain during the very first weeks of life and reduced sleep duration has also been linked to adult obesity as well. So there are a number of ways, since we're talking about growth in children, size in children, there are a number of ways of assessing infant and child growth. So shown here are some typical weight charts for young children that show curves for length. So length is often used in place of height for children under 2, right? And so here we can see, shown here are some typical weight charts for young children that show curves for length and weight by age. So weight and height are often measured in percentiles. And if a child is in the 50th percentile, that will be represented by the middle line or the center line. And so we can see a number of lines here. So it will be the middle line, that will be the 50th percentile range. And so typically if a child goes for a well baby checkup, they will put them on a scale. I don't know if you've seen it done for a sibling or someone in the family. They will weigh the child and then also try to do a length measurement where they put the child on a flat surface called recumbent length and then measure how the child is growing. And so this is tracked over time. So the child is supposed to have multiple well-child appointments where they will measure the weight and the length, and as they grow, the height, and it will be plotted on these curves. So now this is all done on computer, but it used to be done on paper. And so it will be charted, and the doctor will be able to follow how the child is doing over time. And so if the child starts off maybe in the 70th percentile, and they show up all of a sudden and they are in the 50th percentile, then the doctor is prompted to ask more questions as to what's happening with the child. And so this is done for every child. It's done actually globally for most children around the world. Okay. So if the child is in the 50th percentile, that will be represented by the center line, and they are considered average. So average weight, if you're looking for a weight for age chart, they will be considered average weight for their age and for their sex. If you're plotting this on a length for age chart, and they are on the 50th percentile line, how it's interpreted is that their average length for their age and for their sex. And so if they are in a higher percentile, then they have on above average weight. So let's say they were marked at 95th percentile, how that will be interpreted is that they are greater than the average weight, right? So 95th percentile is almost close to 100, so that's a big baby. So there are babies that are much bigger than others. And if they are in the lower percentile, there will be concerns if they are anywhere under the 25th percentile, because that is really low, and that's an indication that there's something wrong. So this is shown more clearly in these growth charts for boys, and very often they are separated by sex, for boys and for girls. And the definition for overweight are children that are anywhere between 85 to 97 percentile, which means that they are heavier than at least 85% of children in the same age group. So children that are in the 97 percentile or greater will often be considered being obese as well. In talking about child obesity, and since our discussion is around obesity through the life stages, it's important to mention child obesity as well in our discussion. And we see that child obesity has increased since the 1970s. And so if we look at figure 15.3, let's look at this is plotting. What we see here is proportion of children and youth overweight or obese, and this is looking at the 1978, 79. It has also split it into age groups, so 2 to 5-year-olds, 6 to 11, and 12 to 17, looking at the age groups. When we look at somewhere around the 1978, 79, and compared to 2004, we can see the differences. So the green bars are showing obese, and then the red bars are showing overweight. You can see it much more clearly. And so we can see that there were no obese children, at least in the population groups that they looked at during this time. However, by 2004, we can see an increase in the numbers. And it's the same when you look at up to 11 years old, nothing for 1978, 79. And so when we come down here, what we see here is proportion of children and youth overweight to obese. Looking at it, these are children who are 5 to 17 years, looking at 2009, 2011, 2013, 2015, and 2017. And so we can see, or at least we can tell from this chart, that obesity has come to stay, and it hasn't reduced over time since we saw more children getting obesity. Okay. So among adolescents 12 to 17, we can see obesity has increased. And in the last 10 years, or last couple of years, the numbers have not increased, but have remained high at about 30% of children and adolescents as well. So what are some causes of childhood environment? Environmental factors are key, and they do have to be taken into account. So children, on average, we can see that children eat more fast food now. They are less physically active because they have play tools that do not require activity, physical activity. They are spending more time in front of screens than their counterparts maybe 40 years ago. So the chart shown here shows a very typical phenomenon of children, that as they get older and proceed from childhood and adolescence, they tend to stop drinking milk, as shown by the blue and pink bars, and they begin to drink more soft drinks, which are shown in purple and orange. And so here we can see the purple and orange ones showing boys and girls and consumption of sugar-sweetened beverages. And then milk consumption is shown in girls with a pink bar, and for boys is shown with the blue bars. And so we can see the ages, and we see that as you get into adolescence, there's increased consumption of soft drinks. And we talked about how sugar-sweetened beverages do contribute to obesity as well. In our discussions in the past, we've talked about that. So the first one is environmental. We're still looking at some of the environmental factors. We also know that parental body weight influences children's body weight. And this is likely a combination of both genetic predisposition to different body weights, as well as the fact that children learn their eating habits from their parents and live in the same environments as their parents. So in this graph, we can see that parents who have a low BMI tend to have children with lower BMIs, while heavier parents tend to have heavier children. Okay. So the main message here is that if you look at parents who are overweight, they do tend to have more overweight children, shown by the bars. And then we look at the obese category. For parents' BMI, we can see increased overweight and obesity as well in that group. So the Canadian Society for Exercise and Physiologists have prepared 24-hour movement guidelines for children and youth. And the guidelines, they do integrate all forms of movement, including vigorous exercise. So for vigorous exercise, examples include, they include exercises that leads to sweating, and lighter forms of physical activity, which they refer to as STEP, or a combination for younger children. And so they do encourage moving rather than sitting, and they do encourage having the right hours of sleep as well. And so we can see sleep here. And sit is often used to refer to sedentary behavior as well. And so they do have recommendations for how many hours a day you should be engaging in these different steps as a way of guidelines to recognize the importance of sleep and also of vigorous exercises and less vigorous exercise as well. Okay. So this figure shows, unfortunately, the Canadian children and youth, that Canadian children and youth meet few of these recommendations, especially as they get older. So more programs and information on how to encourage physical activity among children are needed. And so here we're looking at the percentage of children or youth meeting recommendations for physical activity. Sorry, my mic just died. We just have to use this one now. So this graph is looking at the percentage of children, of youth meeting recommendations, and we can see the recommendations that they met. And so we can see for all three, that is with regards to recommendations around sleep, around physical activity, and how much screen time a child should have. This is the percentages that, so 20% of children aged 5 to 11 met these three recommendations, and then about 5% of children 12 to 17 years met these three recommendations. So it doesn't look too good. So this is a required textbook reading that I have also attached. So maybe we can look at it together. If you go under this week, under modules, you should be able to find the reading attached there. Let us do this reading together. Maybe we'll give ourselves 5 minutes to go through the case study, and then we can come back and answer the questions or try to understand what is being said. So Felicia is an adolescent, age 13 to 15 years. And it's a story about how her obesity is managed by the provider. And then maybe someone can tell us a little bit about the case study. So maybe 1 more minute. So anyone wants to share with us what the case study was about? Yes. Right. So it's about an adolescent who is overweight and getting advice from a health professional as to how to manage weight. So this example, I use this example to talk about how obesity in adolescents is treated a little differently from how it will be handled in adults. So when we look at the graph here at the bottom, we can see growth spurt. It shows growth spurts in males and females during adolescence. Another period in addition to adolescence where there's higher growth rate will be infancy. And so we can see like a spike here as well. And then the growth rate slows down a bit, but then it picks up again in adolescent. And this spike is what we call the adolescent growth spurt. And so it's typical to see adolescents increase in height over a short period of time during adolescence. Okay. So when dealing with childhood obesity, especially when you're looking at the adolescent age, one can take advantage of the fact that children are still growing and they can literally outgrow their obesity. So remember that BMI is a measure of weight over your height in meters squared. And so if the height increases with the weight remaining almost constant or not having sharp increases in the weight, you can have the BMI decreasing. And so very often in children and in adolescents, this approach is used. Whereas in adults, because they have already reached their height, their maximum height, there will be extra efforts trying to really reduce the weight. And so when we look at adolescents, what will be different, or what will be different for children, is the fact that we know they're still growing. And so if we can manage the weight gain so that it doesn't go up drastically, the height will eventually help them to thin out and address the obesity problems. And so the way we treat obesity in children is a bit different than how you would treat it in an adult. Okay. So, and so the approach that was used with Felicia to help her manage her excess body weight was essentially not to promote extreme weight loss, but instead to promote healthy eating habits and to minimize any weight gain while she goes through her adolescent growth spurt, allowing her to literally outgrow her obesity as well. So this will be how addressing obesity in children and adolescents will be a bit different from how you look at it in adults. So that's the case study here as well. Please note that there's another required reading for this section, and this section is on eating disorders. Most eating disorders are diagnosed during adolescence or during early adulthood, although regrettably people are seeing more eating disorders in younger children as well. So the causes of eating disorders are not well understood, but social pressure and the promotion of an unrealistic female body image is believed to be one of the contributing factors. So important to know that there are males who also suffer from eating disorders, although you might find it more in adolescent females than males. So in this graphic here, we see that in the early 1900s, the ideal female body was quite different from what, and as we move through the 1900s, a skinnier body image developed. So the typical body type of today's supermodels, very thin and very tall, is unattainable for most women and unhealthy for models in the industry. And so in recent years, you may have seen calls for the fashion industry to relax their unrealistic body standards. And we do see different body types also being represented in the fashion industry as well. So this textbook reading, it is labeled focused on eating disorders, and it's right after chapter 15, and these are the page numbers. It takes a deeper dive into eating disorders and the different types that we have. So you don't need to learn every detail when it comes to the eating disorder reading, but to prepare for test, be sure you can answer these questions, and you should also read the text shown in the figures, as they provide very important examples of the impact of various eating disorders. So we don't spend a lot of time talking about eating disorders in nutrition class, because when you think about it, it is really a psychological disorder rather than one that is related to nutrition itself. Okay. However, nutrition therapy is one part or an important component of its treatment when dealing with individuals who suffer from eating disorders. Okay. So for example, during treatment for a type of eating disorder such as anorexia nervosa, you have to provide nutritional support to make sure that the individual does not develop life-threatening nutrient deficiencies. And so very often that support is provided as part of care. We also talk about eating disorders in nutrition because it's recognized that people who have predispositions to eating disorders often take nutrition courses. And so this is found out through research. And when you read this, you may recognize a little bit of someone you know in it. And we do want to caution you that this is a disorder that requires professional treatment. Also in the assignment that we did, we do provide resources there of where a number you can call to get support if this is something that is a problem. Okay. So while we tend to think of eating disorders mainly focused on women, men also suffer, and there's a lot of evidence that men are being subjected to male body images that are as unrealistic as female body images are for women. So a number of years ago, this is just showing an interesting picture of how even the toys that we use have changed over time. So a number of years ago, a very interesting article came out that looked at male body image as represented through action toys. And so in the top photo, we have a picture or pictures of a toy called G.I. Joe. And you can see it from 1964 to 75 to 94. G.I. Joe was increasingly bulking up as we look at it. So this is similarly the case for Luke Skywalker. I don't know if you recognize these toys. Luke Skywalker and Han Solo. And this is how they looked in 1977 when Star Wars was first released. And this is how they look 20 plus years later, okay? So this kind of muscular development is as unrealistic for most men to attain as the skinny fashion model ideal is for women as well, okay? So finally, the last part of our discussion is focused on nutrition and aging, so weight changes during the adult years. And we do know that weight issues can also arise during the adult years. So the good news is that we are living longer than ever before, and you can see in the figure how life expectancy in Canada has been increasing. And so we see year of birth. On average for males, we're seeing 79.9, that's almost 80, and females about 84, which is good to see. So, but despite the longer life expectancy, aging increases the risk of malnutrition and weight loss rather than weight gain. So this graphic shows the cycle between malnutrition and resultant reduced muscle mass which occurs as we age. And this type of reduction in muscle mass is what we're calling sarcopenia. And changes in immune function that also comes with aging during this period. And so, and it does make older people, much older people, susceptible or vulnerable to disease due to some of these changes that occur. So first of all, the decreased muscle mass makes it more difficult for an individual to access food. So it's harder to go and shop for food or to prep a meal, and this can result in decreased nutrient intake. And so typically, if older people live alone, it becomes a problem and a concern because they may not be able to prep their own food or move as efficiently as they used to do. Okay? And this can result in malnutrition because they are not getting the nutrients that they need. And it can also impair immune function, right? Because they need the right nutrients to support an immune system that can mount the necessary response that they need. And so very often, you have malnutrition happening. You can also have illness as a result of the impaired immune function. And then there is also increased use of medication that comes with this age as well. Okay. And so all of this complicates the issue, and this increased nutrient need coupled with less intake resulting in malnutrition. And the cycle continues as malnutrition increases, you have this muscle loss or sarcopenia also increasing and reducing immune function. So it's important as adults age to maintain a nutritionally balanced diet and to exercise to maintain the muscle mass as much as they can. So here again, I show physical activity guidelines for older adults, and they do not differ very much from those for younger adults that are shown in the supporting document. So if you haven't seen the supporting document on exercise, please take a look at it. It talks about exercise through the life stages as well. Okay. And so they do, in addition to what we see for, it's very similar recommendations to adults, but in addition, we do see a recommendation for physical activity that helps to promote balance and prevent falls, which is a more serious issue for older adults because it often leads to very negative outcomes, health outcomes. Okay, so this brings us to the end of the slide. Please make sure you're going through the self-assessment questions. There's one for section 1, one for section 2, and one for section 3. So just a quick announcement I posted today, I don't know if you've seen it or last night, about the changes to the quizzes. So I had a few students show me the mixed up dates in the quizzes. So all the quizzes from quiz 7 is open till April 3rd. Please note that there can't be any extensions beyond April 3rd because that's the last day of class. And so make sure that you take a look at the quizzes and you complete them. You now have 2 attempts, and the highest score will be used for your mark. Okay. Have a good rest of the week and have a good weekend. I'll see you next week. Yes. Bye. Let me just turn this off.